I'm Dr. Russell Libby, and I welcome you to the world of medicine. A good night's sleep. I think we all dream of waking up refreshed in the morning, feeling every day like we just slept like a baby. Well, I am sorry to say that for most of us here in this Northern Virginia area, that's more of a rarity than it is a regularity. And certainly we blame it on lots of different things. Oh, we ate a big meal last, too much caffeine, chocolate, whatever it was that kept me up a little bit too long. Or maybe it's just the stress. We're worrying about things, paying bills, getting to work, giving the talk, whatever it might be. Or if you're a high school student here, my God, staying up till midnight doing your homework and then having to be in school by 7:20 the next morning. Well, we know there are lots of reasons. But in fact, sleep is something that is hard to come by for a number of people, for quite a few in fact. And there are some very interesting and very complicated conditions that we think may cause problems with sleep. What's even worse, there are a number of significant medical complications that come with not getting adequate amounts of sleep. What does sleep do for us? What's it do for our brains? What's it do for our bodies? Why do we need it? Well, we're going to find out a lot about sleep in this show. We've got a great studio audience. They're going to share some of their experiences with us. And we've got a wonderful, world-renowned sleep specialist, Dr. Pankaj Murchia. He's a sleep specialist. He has clinics in Frederick and Rockville, Maryland, but as well here in Reston, Virginia. They call them Sleep Heart clinics. I'd love for us to first sort of get a sense of what sleep is all about. So give us the old 1-2. What is sleep? What are the stages of sleep? And help us understand a little bit about what the physiology of sleep is all about.
That's great. Thank you for the introduction. I think you sort of hit the nail on the head as you sort of said sleep is a process where it's not a passive process where you just sort of drift off and then suddenly you wake up. It's actually an active process. The brain actually prunes itself through sleep. Sort of think of it as the hedging or the landscaping work being done at night. It lets you formulate memories and really makes it possible to live. Without sleep, any animal dies over time. The stages of sleep. Stages of sleep they used to be broken down into 5 categories, stage 1, 2, 3, 4, and the famous REM, rapid eye movement sleep. It's now called N1, N2, N3, and rapid eye movement sleep. What really drives all of this is that there's actually a clock gene, and it's present in every single cell in your body. From your skin cells, actually have a sense of time of day, to your brain. The greatest driver of this clock system is the sun. In an area of your brain called the suprachiasmatic nucleus, right sort of between your eyes and a little further back, it takes cues from the light that strikes it, and it sets the clock. And that clock is a little over 24 hours. It's present in animals. It's even present in plants. You know, they did this great experiment in the 1800s where they actually took a flower pot, and every morning it would sort of bend towards the light, and it would open. Now, is it doing that in response to the light, or is it doing it of its own accord? A fellow named de Marin put this into a cardboard box, and he saw at the exact same time it did the exact same thing. So it's really a circadian rhythm, around the clock rhythm, that drives life and function.
It's always interesting to me when you say a circadian rhythm, because I think of babies in utero and they have their days and nights the way they live them there. They don't respond to sunlight. They just respond to some biological process that has created a day and night rhythm. They're moving, they're active. And then when they come out, they sort of follow the same clock, and it may not actually be the one that we like them to follow, and a lot of people have to deal with that. So we've taken those deep stages of sleep and put them into one category. Now, when we think about sleep, when we lay down to go to sleep, we start off, I would imagine, that N1 or that stage 1 sleep.
We sort of start off in what are called the shallower stages of sleep, stage 1, stage 2 sleep. Then we would drift off into what's called slow wave sleep, or stage 3, 4 sleep, or now N3 sleep, and then ultimately into rapid eye movement sleep. Normally in the course of an 8-hour night, you would actually have typically 3 or 4 cycles where you've sort of started off at wakefulness, gone to 1, 2, 3, REM. And REM is an odd thing. Some people call REM down here. Some people say REM is right up here with wakefulness because it looks a lot like wakefulness in terms of electrical activity of the brain. And then they'll sort of rise back up and then go back down, ultimately having 3 or 4 blocks of REM, sort of, if you thought of this as mountains and valleys, you're sort of going up and down on this roller coaster through.
So the cycle for people with sleep, then they have these lighter stages, the ones where you're fairly easily awoken and you actually can get up and respond to things, and then as you fall deeper into sleep, and you're into that groggy, deep sleep. And then the REM, where you say you have a much more active and it's almost like another dimension for your brain. Is that a time when we are getting the most out of our sleep? I mean, that was traditionally what was assumed.
It's actually really hard to figure that out. They've done experiments where when individuals enter a particular stage of sleep, they'll do an acoustic cue, something to arouse them, to try to selectively knock out different stages of sleep. And they found that, in certain elements, motor learning skills versus verbal learning versus assimilation of memories are differentially affected by selectively knocking out those stages of sleep. All of those experiments, they're challenging and they're really confounded. I think it seems clear that everybody needs 7 to 8 hours sleep, and there's a very small fraction of the population that really needs less, the short sleepers, and a small fraction that needs more, the long sleepers. But 95% of the population needs 7 to 8 hours of sleep, and a combination of those stages is restorative. Probably the most published literature is when patients don't have enough REM sleep, rapid eye movement sleep, and that's frequently associated with pain disorders like fibromyalgia and the like.
So there may be some association with other kinds of diseases that way, or conditions, let's say. And just trying to delve in a little bit more, when we talk about those stages of sleep, when we dream, when does that occur? What stage?
Most people would consider dreamy sleep to be rapid eye movement sleep. From your brain's perspective, frequently people will replay experiences of life. Their brain is acting just as if they were awake, but they're paralyzed. And that paralysis is sort of one of the 2 hallmarks of rapid eye movement sleep. And that's dreamy sleep, if you will. I don't think hormones have really been identified as being a driving factor for the decreases in the duration of different stages of sleep or sleep in general. One thing's very clear: if you do serial MRIs or functional MRIs of developing children and infants, you'll see incredible remodeling of their neural networks. You can imagine, going back to that landscaping analogy, the first cuts lay out the big picture of what trees and bushes are going to grow where and what general shape and form they're going to take. And then later on in life, you're just doing the fine maintenance of those. And given how much of underlying development and laying out general form takes place in those first years, it seems reasonable that we need more sleep to do that.
Right. I would imagine then, so as they get older, children need less total sleep, and of course, a proportionately less amount of time in that REM sleep. And by the time they're teenagers, are they pretty much where they need to be for adult requirements?
I think it tends to stabilize. If you look at individuals from their mid-20s, where the typical sleep requirement is maybe 7 hours and 45 minutes or so, to by the time someone's in their 60s, over that 40-year spread from the 20s to the 60s, there's maybe about a 20 to 30-minute decrease in required total sleep time. I use the word required. Where does this come from? And a lot of this stuff actually comes from the 70s, where they had these sleep camps where they would measure, they would let people sleep, and they would actually say you need to sleep, and you'd be allowed to sleep freely as much as you wanted. And they measured reaction times. And they started off with individuals who were sleeping, I only need 6 hours a night. I'm perfect on 6 hours a night. And they looked at their reaction times to when something was shown in front of you and when you actually responded, that acknowledging it, pressing a button that you saw something flash in front of you. And the reaction times were longer. And after people had sustained 7 to 8 hours of sleep for some time, those reaction times went down. They've similarly correlated. A lot of this research was done out at Stanford, where they looked at grade point average for students. And I think you mentioned this in terms of our adolescent teenagers who were kept up till midnight doing homework or with the computer and wake up at 6 a.m. to get to school at 7:20 in the morning, where people who sleep more actually have higher grades. Imagine that. By sleeping, you actually learn.
And I thought you had to pull an all-nighter to get a good grade, right?
That's actually probably the worst thing.
I would imagine.
Even for doctors, I'm sure back in your day and when I started my internship, working 30 hours at a stretch was considered expected.
Absolutely.
Well, the ACGME, as of this year, 16 hours is the upper limit.
Right.
We're finally catching up with the rest of the world, which realizes that all we do is kill people by not sleeping.
And ourselves. By making ourselves do that. But I do want to hear from some of you a little bit about how, I guess sleep or the lack of it has really had its impact. You had insomnia.
Yes.
Starting about when?
Starting about July or August of this year.
This year?
Yes.
And you never had any problems
I'd
with
had
sleeping?
brief periods of insomnia before, but they would always resolve. And this time the insomnia was persistent. And over the course of about 2 months or more, I just continued not being able to sleep. And as on the advice of another doctor, I went to Dr. Machia and had a sleep study, not really expecting to see much, because the night of my sleep study, I slept through the night.
The way that sleep apnea is diagnosed is through something called a sleep study or a polysomnogram. It's a situation where a patient, whether it be a child or an adult, children would typically come with a parent, come in at about 8 to 10 o'clock at night, and they get hooked up to a number of sensors, and here is sort of a flurry of wires that are hooked up to you very much how an EKG would be hooked up. You've seen the sticky electrodes on television shows where they do your electrocardiogram. This involves an electroencephalogram, which measures the electrical activity of the brain, along with an electrocardiogram that measures your heart, measurements of your chest and belly, and finally something in front of your nose and mouth to see how much air you're moving. A common question people have is, gosh, am I going to be able to sleep with all this stuff hooked up to me?
I thought, oh well, what possible result could we get?
Well, that's just what they wanted you to do.
And I came back, and the reading was that my blood oxygen had dipped to 79%. And I was having the apnea events very, very often, and it really shocked me. So, and then, of course, when I started using the CPAP machine, immediately I noticed an ability to fall asleep.
So initially, it was falling asleep that was hard for you to do?
Yes, it was falling asleep, and eventually then staying asleep.
I guess insomnia is a fairly generic term that we use for a lot of people who just feel they can't sleep, but how do you define it?
Insomnia is broken down into two broad categories: onset insomnia and maintenance insomnia. Onset insomnia being difficulties falling asleep. The most common cause of that is psychophysiologic insomnia, where for most people it's a set of bad experiences associated with sleep that make them dread sleep in some ways, or it's hyperstimulation from their environment and focus on activities in their daily life that that prevents them from sort of releasing and letting go of those elements so that they can fall asleep. For a number of patients with apnea, as Lisa described sleep apnea with drops in oxygen levels, what apnea really is it's effectively the airway collapsing. The analogy that I give for it is, imagine as you're drifting off to sleep and someone takes a pillow and suffocates you. Suffocates you until oxygen levels start to drop, carbon dioxide levels rise, and then your brain wakes up. Oh my gosh, if I don't breathe, I'm going to die. Well, imagine if I was laying here and someone suffocated me. I can assure you, the next time I was thinking about going to sleep, I'd be a little scared. And it used to be that, if someone has insomnia, they don't have trouble sleeping. There's no chance that they have sleep apnea. It was considered foolish to even do a sleep study on those patients. But now I think we've learned that a number of these onset insomnia cases could be sleep apnea. A number of them are restless leg syndrome, where people have what they call an urge to move their legs. It's an urge to move. The U, the R is that it is more prominent with rest. So if they're sitting in a plane or sitting in a car, they'll get fidgety in their legs and they'll get this creepy, crawly sensation. The G in urge is that it gets better with activity, and the E is that it's more prominent in the evening. A number of pregnant women, as they get iron deficiency, will develop this. Menstruating women will frequently have this from iron deficiency. And then those with kidney problems will have this later on in life. It's really remarkably common. Even in the pediatric realm, children who toss and turn and move around a lot at night, and parents say that their bed's entirely disheveled by morning. It's amazing, I'm sure, from your experience, how many of them have low iron or ferritin levels. So those are the onset insomnia: psychophysiologic, restless legs, and insomnia being the three I most commonly see. And then the maintenance insomnia, the most common complaint that I get from patients is, oh, I don't have a problem staying asleep, I just have to get up to pee. But then you ask them, if you're a man, well, do you have trouble peeing during the day? Well, they say it's my big prostate, but do you have trouble peeing during the day? Do you have to pee frequently, or does it take a long time to get a stream going? And they say no. So it makes me wonder, is it really the prostate? And a number of these patients, if they turn out to have something like apnea, their nocturia, their peeing at night, disappears just with their staying asleep. The question is, are you waking up to pee, or are you waking up and then saying, I need to pee? And then similarly for women.
Yeah, well, I know that we have an interesting
postmenopausally.
story from you. We had talked a little bit earlier, too. That was something that you suffered with, but you don't have a prostate.
Yeah, but every night I could not sleep all the way through the night.
And every night, what was going on? You had no problem falling asleep,
Oh, I was passing out. I was tired.
and you were tired all day, too?
Yeah, yes, I was tired all day, and there was like an inner anxiety all the time, too. I lead a very active life, but there was a level of anxiousness there.
That you
And
weren't going to sleep well enough and you wouldn't be able to respond to the demands of the day that your active life required. Is that what it was?
I don't know. All I know is there's this inner anxiety. I have a sneaky feeling now that that's what my body was telling me,
Right.
that I was having issues. But every night I would have to get up and use the restroom.
What time would that happen?
1, 2 o'clock in the morning.
Just once?
Just once normally, but I was only getting like 6 hours a night anyway.
Right.
So
And
every
then that
3
was
hours.
enough to really throw you off.
Yes,
Yeah.
yes.
Did it affect your personality?
Yes,
Yeah.
it did.
So not sleeping makes you
Cranky.
cranky. Yes. All right. And you have gone through some workup. I mean, how did you deal with this in the first place? I mean, you've been. How long were you going along, waking up at night, going to the bathroom?
It'd been over a year.
Okay.
And then I was very lucky that Dr. Machia actually came to my Sunday school class. And I just thought, hey, my parents have to get up in the middle of the night. This is just a product of being aged. It's a product of menopause. It's just the new reality. And so when he started describing some of the symptoms, and it was like tick, 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 tick. So a week and a half later, I was doing my sleep study.
All right.
And found out that I stopped breathing 47 times an hour, and my oxygen level got down to 65%.
Wow,
So it was a big deal.
it was a big deal. And there's been a big change.
Oh my gosh, yes. So huge change. It's really like fun to be with her. She doesn't, whenever you don't get enough sleep, you just get so much more angry during the day about like the smallest things, but now it's just kind of a breeze through the day with her, so it's
That's
cool.
great. That's wonderful. Glad to hear that you're going to Sunday school, Lucia. It's a good thing. There are two things here. One, of course, is that issue with people waking up in the middle of the night and thinking. And I know that you had told me also that sometimes you had a sense of throwing up.
Mm-hmm. I actually woke up with GERD in my mouth sometimes.
And was that due to the gasping? Was it due to reflux? Was she eating at the wrong time? Was she eating the wrong foods? I mean, we hear a lot of different stories.
I mean, reflux is a really interesting thing. So if you were to imagine right now, take a deep breath for me. What you'll do is you just lifted your chest and you sucked air into your lungs. Breathing in is a suction process. So imagine if I'm trying to suck air into my lungs and my airway collapses. I'm lifting my chest, trying to suck, suck, suck. Well, if you can't get air in from outside, you do the next best thing. You siphon the contents of your stomach up your food pipe, up your esophagus, and then portions of that can trickle into your airway. When it trickles into the airway, people will choke and gasp. In terms of pressures, right now as you're breathing, you're sort of siphoning probably -5 to 7 centimeters of water, a glass of water this high. People with sleep apnea will drop their pleural pressures in their chest to -30, 40 centimeters of water.
They'll be sucking hard.
So it's all of a sudden this height. Well, gosh, that's enough to siphon from your stomach easily into the back of your throat and into your airway. For some people, it'll lead to asthma and nocturnal coughing and flare nocturnal asthma. For others, they'll have a sour brash or a taste of their night's dinner in the back of their throat.
With a jolt.
Yeah, with
a
a
jolt.
jolt. And Protonix isn't always the answer, or Nexium isn't always the
And
answer.
it wouldn't make sense that it would be in that situation, for sure. It also describes something that I think when you're talking about people, their normal respiratory drive is going to make them want to use their chest wall to breathe. And they may breathe a little bit harder, but eventually it has to be a voluntary effort, and that's when they wake up. Is that what's going on at night for those who do wake up through the night with their apnea?
You know, it's interesting. Right now, as each of us takes a breath in this room, the muscles of our airway, our glossopharyngeal nerve innervates our genioglossus, genio being the knee of our chin, to our tongue, our glossus, and it literally pulls your tongue forward and it opens up your airway. Happens about 30 milliseconds before your diaphragm contracts maximally, breath after breath. So many of our reflexes fade away at night, this one fades away. We like to be able to speak as I'm doing now, so we are the only mammals with a mobile hyoid bone, a bone which is sort of like a U here, so that we could speak and do other things with our throat is now mobile. So we have an unprotected airway. So what's happening is that you're relaxed, and then you're sucking air in, the airways collapsed. Ultimately, it really requires an arousal of the brain, which is going to reactivate that reflex in the muscles in your airway to open it up. It's not just the sucking, because the interesting thing is once an airway is collapsed, the harder and harder you suck from your chest, you're just going to collapse it even more. I mean, just take a straw, collapse it, and then try to suck. It'll cause even more of the straw to collapse.
So that may contribute to the lack of continuity of sleep. I mean, if you can't go through those stages of sleep and achieve the more restful periods because you're constantly being tossed back into stage one or...
You know, it's normal for all of us as we sleep to arouse between 5 and 15 times an hour. You know, the teleologic explanation is if I were a caveman sleeping, I would want my brain to periodically arouse and make sure there wasn't a tiger about to pounce on me. But folks with apnea will have 50, 60, 70 arousals an hour. So every minute their sleep is getting fragmented, just like someone taking a metronome and snapping every minute as you sleep. It abolishes their REM sleep. Many of them will have decreased REM sleep as a result of that. Many of them will have completely lost their slow wave sleep. For many apnea patients, by the time they get diagnosed and treated in their 50s, they never regain their slow wave sleep.
Pretty incredible that we can have such a complicated process to do something that seems so easy for us. You had some issues, much like he was describing. You had some issues with asthma.
Yeah. I had issues with asthma. I used to fall asleep and snore, which my family identified, and they said I needed a sleep study and found that I had sleep apnea. My oxygen content also went down. It sat up to 70s. And initially, I was very, very reluctant, and it was very hard for me to start using the mask, but now I really use the mask. And the cough, unbelievably, the cough has stopped quite a bit. And not only this, I'm also diabetic. So I used to use the restroom at night, minimum 3 or sometimes more, But since I'm using, I don't wake up to go to the bathroom.
That's pretty interesting. The fact that people think as they age, they're going to go to the bathroom more at night. And it may be that it's much more related to sleep. And just that consciousness that makes you more aware of your bladder, and that's what you end up doing. And what's fascinating to me, now, do you have a lot of allergies? Have you had asthma through your lifetime, or is this just something that sort of came on later in life?
No, later in life, much
and
later.
Did you ever get evaluated for reflux disease, too?
Yes, yes.
And of course you...
No, I didn't have.
They didn't suspect that you had
No,
reflux
they gave
disease.
me some, but it wasn't related to reflux.
Yeah. So are there certain chemicals that might be released in the process when you have those periods of apnea that may cause some reflexive bronchospasm? Or do you think that there's a little bit of reflux that may have caused a little aspiration and chronic inflammation and that sort of thing too?
I think it's more the latter. I think it's microaspiration. You know, most of the assessments which they'll do for reflux, you know, they'll be using pH probes, looking at acidity and seeing how much comes up. The sensitivity of those, especially if you put someone on a proton pump inhibitor, Nexium-like drug, their pH goes up. They no longer have the acid to trigger that. So I think it misses a great deal, and it doesn't take a whole lot. I mean, if I'm drinking a glass of water at the dinner table, you need a fraction of a drop to go the wrong way for me to wind up coughing.
Sure. Absolutely.
It doesn't take a whole lot. And the thing is that our airways are pretty sophisticated. All through the night, we're all swallowing all night. We're producing saliva through the entire night. So we're constantly having to clear that part of the airway. Anything which is causing any inflammation or any abnormal function of that area, it just sets itself up for microaspiration.
Well, now we heard about a family who tended to remind her that she was snoring.
Well, my wife Debbie told me over 10 years ago that I was snoring, and my dad snored terribly. And being a dentist, I have gone and taken courses on appliances that could be fitted by the dentist to advance the lower jaw. I brought a couple samples here, and for several years they did help. But the one thing that never was able to be taken away was the terrible headaches that I've had all throughout my entire life. Huge amounts of Advil, and waking up at 4 or 5 o'clock in the morning with terrible, terrible headaches. And it was my urging of my wife Debbie to go and get a sleep study. And oh, by the way, I even had surgery done, laser surgery on the roof of my mouth. I've had everything done, and it did not help. And the sleep study did show very, very low oxygen and many, many episodes of not sleeping. She would describe my snoring as like the hound of hell, she would call it. And she actually suffered from insomnia also, because there's two people in this equation. The person who has the apnea and the partner who suffers terribly from that. And the psychological and physiological effects of not sleep is quite pronounced. But I finally went and swallowed my pride and got the CPAP, and I thank God for that, because with the CPAP, I sleep so well. The headaches are gone. I have not had a headache in 3 years. No more Advil. You know, the dangers of taking long-term Advil and end-stage kidney disease. And so I was aware of that. And my mood and my ability to practice dentistry, everything has improved. I no longer drift off as I'm driving home on the toll road on 4 or 5 o'clock in the afternoon, which can be very dangerous. And Debbie is quite happy. She did say, though, she's now sleeping next to Darth Vader. But he's a pretty cool guy, you know.
But it's interesting. So here are some more symptoms. People having headaches through the day, having a hard time staying focused.
Yes. Mood.
Feeling moody and
terrible.
And having to dread certain chores that you would have to do on a day-to-day basis. I'm sure that sitting and reading a book in bed was like taking a sleeping pill for you.
Oh, it affects, you know, you start becoming depressed, and your whole your whole family life changes, especially because your wife isn't sleeping, and you think you're sleeping, but you're waking up all the time. You're waking up with headaches, and you're grumpy during the day, and you're not as efficient, and you chalk it up to age, but it's not age. It's you are slowly suffocating, and your body is responding to the suffocation, but because the sleep cycles don't occur, you are a shell of the person you used to be. And I'm so thankful now that I'm very similar to how I was many years ago.
Well, this is Dr. Barry Laurent. He's a dentist, a general dentist in Tyson's. He's excellent. And I know that you've sort of really taken an interest in people's sleep, their neck sizes, their habitat.
Because of my experience with apnea, and on my medical questionnaires, I ask, I ask them if they snore, but a lot of times I need to, if their wife comes with them, I ask the wife if they snore, because they'll say, no, I don't snore, and she's saying, yeah. Or I ask the children who are down the hall. And then I look at their neck size. If they're 17 and a half, I definitely ask questions. I look at their profile, if they're retrognathic, if their lower jaw is back a little bit. That means it's easier for when you fall asleep for the airway to collapse. And through that, I make suggestions of either having the oral appliance made, but more and more, I'm recommending sleep studies. I have prescriptions that I write for sleep studies because I don't want to give someone a device that is not going to be effective. And what happened with me is I kept trying to advance my lower jaw farther and farther forward, so my bite actually changed. And wouldn't it have been nicer if I had just done what Debbie had asked, gotten the sleep study, and been diagnosed much sooner and have the CPAP with the humidified air? It's absolutely wonderful. And so many of my patients do have hidden apnea and also clenching. I was going to ask you about the bruxism, because there seems to be a whole relationship between nighttime grinding, clenching, leg movements, and inability to sleep well. And I didn't know whether you could comment on whether you've noticed there have been studies concerning bruxism with lack of regular sleep patterns.
So I've actually looked to see in terms of published literature correlating bruxism and sleep apnea. There isn't a lot of literature. However, physiologically, bruxism, as we grind, we activate those pharyngeal muscles, which I described earlier, and it actually increases the patency of the airway. I have a huge number of patients who are bruxers who, once you treat their apnea, their bruxism fades away. So for TMJ, temporomandibular joint disorders, along with grinding teeth, I think one of the first things to look at is look for sleep apnea, because it's really an adaptive response to grind and to brux and to try to move your jaw forward, to breathe.
You have some of those dental appliances. Do you use them much?
Are
there certain situations where they're... Here, you can show it to us.
Well, this one is designed so that you put it over your upper and your lower teeth, and it works by advancing the lower jaw forward. And you have elastic straps. They have some that have replaceable arms that have different lengths to slowly bring the jaw farther and farther forward. But if you're a clencher and grinder, it's very difficult to use these devices. This is a device that's recently been marketed by a Glidewell laboratory, where you actually stick your tongue into this, and it props up against your teeth, and it pulls the tongue forward so that you are attempting to pull this wishbone, this hyoid bone, forward to open up the airway with limited success. I think what the person is trying to avoid doing is having the gold standard, which is the CPAP, diagnosed and made for them. If the snoring is a rhythmic snoring, it's a light snoring, and it's enough to irritate the person's wife, these devices can work. But if they have apnea, I mean, you could pull your tongue all the way to that wall back there, and there's only so much you can do physiologically.
It varies from patient to patient. The current guidelines would be for patients with mild obstructive sleep apnea. It's reasonable to try these mandibular advancement devices, as they're called, to do this. They may or may not work. Sometimes they work in moderate cases as well. But the really important thing is, after you get that appliance made and adjusted, to make sure it actually solved the problem.
Right.
The problem isn't just the snoring. The problem could be the stroke or the heart attack or the other complications that can ensue from apnea that can really be silent killers.
So, since you mentioned it, there are some pretty significant issues that data seems to show that people with sleep disturbances have a much higher incidence of stroke, as you say, and heart attacks.
Yeah, in severe cases of apnea, it's a 4-fold increase. That's more than high cholesterol. That's more than high blood pressure alone. That's more than more than diabetes alone. People saying peeing at night and nocturia, to asthma, to heartburn, to headaches, to memory, to, you mentioned, depression. I mean, this has got to be a myth. How could sleep something cause all of these problems?
You know, of course, you're talking about also before the fact that there are other sleep disorders that disturb your sleep that aren't necessarily due to obstruction, but are due to certain movements that you biologically are compelled to do.
Yeah.
The restless leg.
Restless
and
leg.
There are other
periodic
limb disorders of
periodic
sorts.
limb movements of sleep. A few years back, there was an interesting case where a man murdered his wife at sleep, and he blamed it on he was asleep, and that was his plea. That's obviously on the extreme, but I actually have patients where one partner has strangled the other partner on a regular basis, and that's REM behavior disorder. It's rapid eye movement behavior disorder. That paralysis, which I said really defines REM sleep. The paralysis is missing. Everything else is in there. Alcohol can trigger that, bring that out for patients. There's a whole host of movement disorders. Probably the number one sleep disorder that as a society we suffer from and actually has real ramifications is sleep restriction, not sleeping enough. The studies are very clear. The Nurses' Health Study, where they followed thousands of nurses over decades, show that those who work nights, those who sleep fewer hours, are more frequently obese and gain weight, have higher rates of diabetes, have higher rates of heart attacks and strokes. So duration of sleep is clearly an issue. For grades for our children, getting them up at 7 a.m. is shooting them in the foot to help them succeed.
Well, and you work at the FAA, right?
Yes, I do.
And my God, I can't imagine any place I'd rather have everyone have to do a sleep study than those who fly us around this country or this world.
Absolutely. Pilots, it's a very important issue. The Federal Air Surgeon recently, in his regular newsletter, put out an article specifically dedicated to sleep apnea, and to urging pilots with any sleep problems to get a sleep study for exactly that reason.
So we're hearing first that people with diabetes, people with asthma, people who are overweight, they're all at risk for having sleep disturbances. And those sleep disturbances are putting them at greater risk to have worse disease that they have, and ultimately can cause their demise. Now, your son, I know we were talking about anatomy, and it seems that in the adults that it's not the panacea to clear out that tissue that seems to have that much of an issue relative to the shape of the palate, et cetera. But your son had some issues in school for a few years.
Oh yeah, he had trouble studying, concentrating, grumpy. You know, he gets up at 6:15 in the morning, gets home at 4:30, and we went to Dr. Machia based on a recommendation, and he was waking up 64 times an hour.
Wow. But I mean, he had been through a lot of educational testing, and
Right.
you've been going through probably a lot of experiences that really made you feel bad about yourself, like you knew you were smart, but you just couldn't do that well in school because it was hard to focus. And did they have you take medicine for that too? Did you ever have to take any medicines for school or anything like that?
I had to take focus pills to help me concentrate.
Right. So everybody sort of figured that was attention deficit disorder. It's a very common diagnosis in kids. And you had no idea that it was hard to sleep?
Yes.
You did know, or you didn't know? You had a hard time sleeping, or it just never ever occurred to you that was a problem?
I didn't know I had a hard time sleeping.
Yeah. How was the sleep study for you? Was that okay?
It was really sort of annoying.
I'm sure.
With all the cords and stuff.
Yeah.
And,
It was hard, but he did it. He persevered. He went through it. He did it.
Oh yeah,
And what's happened to his grades and his school performance since?
You know, ever since before the surgery, we had him on the CPAP machine.
Right.
And, you know, Dr. Machia and his whole staff, would adjust the machine to make sure he's getting enough air on a regular basis. And his grades, you know, A's and B's. And, you know, recently we just, after Dr. Machia's recommendation, we had surgery. And you know, we just had the final sleep study and, you know.
So he's off CPAP now?
Off CPAP now.
Yeah, I'm sure that's a relief. Yeah. So this is the other side of the pediatric equation now. We're seeing kids who invariably are suffering in school, having a hard time staying focused, irritable, sometimes getting in trouble, impulsive, things of that nature. And some of them have to be related to sleep issues. His was associated with, I guess, large ear, nose, and throat tissues. He had a tonsillectomy and adenoidectomy. So that does sometimes really solve a problem, at least in kids.
Yeah, for children, probably about 70% of the time it solves the problem. But I'll share a couple of nuances from the literature. If you look at all comers of children with ADD, ADHD, if you carefully question them about difficulties falling asleep, remaining asleep, being rested in the morning, you'll find that more than half of them actually have some issues there. For that about 60% that have some sleep-related complaint, they've actually done sleep studies on those groups where they took everybody who came in, had an ADD, ADHD diagnosis, and had some sleep issues. And it turns out that 60 to 90% of these children, depending upon the thresholds you use, actually have sleep apnea, 60 to 90%. It's amazing that, you know, ADD, ADHD, a hyperactive disorder, gets better with Ritalin, an amphetamine, a stimulant, an upper. And the issue is that these children are hyperactive because they aren't sleeping well. And then in terms of treating them, you know, I think pendulums swing back and forth. You know, if you talk to people who are older in the 50s, every child had an adenotonsillectomy. If your parents could afford it, it was the gold standard. What else could you do for your child other than get an adenotonsillectomy? And there was a tremendous backlash against ENT surgeons that they're operating too much. I've seen over the last couple of years a number of patients who had seen ear, nose, and throat surgeons and been told, your adenoids and tonsils aren't that big, don't worry about it, there's no need to do surgery. And when we study those children, if they actually have sleep apnea, even what seems to be normal or slightly larger than normal adenoids or tonsils sometimes give you a huge bang in terms of opening up the airway. When you go see an ENT, he's seeing you during the day while you're awake, while all your defense mechanisms and muscles are opening up your airway. The question is, what happens when those defense mechanisms are gone at night? That's what really matters.
Right.
And then even after surgery, 20 to 30% will continue to have apnea. And the interesting thing there is there's always turf wars. If you talk to ENTs, once I'm done, their apnea is gone. Well, they're clinically a lot better, but there's still residual apnea.
Sure.
And the thing is, for children, sometimes dentists, orthodontists can potentially help with things like palatal expanders and changing how the jaw grows and develops over time. And sometimes if they still have significant clinical symptoms, I'd rather breathe when I'm a growing brain than be suffocated. It's described as brain death by small hypoxic cuts in the pediatric sleep literature.
So there's a lot for people to discover, and there are other kinds of medical issues that occur to people. And I know that you had a pretty exceptional event. I mean, you just remember one day just sort of feeling bad, and it was the beginning.
Late November of 2006. Pain, stiff neck, couldn't sleep, my feet were cold and numb. And how long did not being able to sleep go?
It was a couple of years.
Yeah.
So you just suffered with it for a couple of years. Figured you were a teenager. It's typical for kids.
No,
and
I had Lyme disease.
You had Lyme disease, right? But I mean, that's what did you discover that early on?
No.
No. It took a while before anybody
Couple
decided
months.
to try that. And then, And then how did things go from there?
Well, I could go 4.5 days without sleep, several times ending up with hallucinations and various forms of synesthesia.
People kept trying to give you medicines to sleep.
Which
And what
gave
kinds
me
of medicines? Yeah, I
hallucinations and
imagine. What kinds of things like Ambien, and
Lunesta.
Sonata, and Lunesta?
Sonata, amitriptyline was one of them.
I figured you were depressed too. What the heck?
Yeah.
We'll try to treat you for that as well.
Yeah. Chlorohydrate, Xyrem finally worked.
Did you ever do things like melatonin and all those other kinds of things? You tried all the...
Yeah, and trazodone was another one.
The wishful thinking medications.
Yeah.
If it was
Placebos.
just a little bit, you could get you down for the night and you'll have a good night's sleep and all will go away and all will be better. So you had a sleep study done eventually.
Yes.
And what did that show?
It showed well, you probably could answer better than I can because I don't remember most of that time.
Sure. It actually showed mixed sleep apnea, both obstructive and central sleep apnea. And in distinguishing those two, obstructive is where the airway collapses. There's ongoing effort to breathe, but the airways collapse, so air doesn't come in. Central sleep apnea being where the brain doesn't remember to breathe. Things get confounded as you add medications on board, which can certainly lead to the central sleep apnea. It's quite possible, as he mentioned, that infections of the brain could also impair the brain's ability to try to breathe on a regular basis. So it's an interesting mix of how portions of it could be iatrogenic with medications, portions of it could be infectious, can impair the ability to breathe, both.
So, a good explanation, one that's sort of hard to recount yourself, I'm sure, but you spent a lot of time, I guess you took some significant treatment for the Lyme disease, and it's interesting that these kinds of illnesses can do that, and certainly something that you always have to think about as well. You've done better since then. You were on a pretty intense regimen of CPAP and things of that nature.
Yeah, CPAP, BiPAP, ventilator, supplemental oxygen. Originally, it didn't really help, and it was so painful that in my legs that it took like an hour to get out of bed. Did we ever figure out what caused that?
You know, I remember a very peculiar thing that both you as well as a few other Lyme patients have shared with me, that when you've wound up in the hospital for other reasons and you've been put on supplemental oxygen, that your pain improved. When you first started using CPAP and BiPAP, I remember you're saying that now that you were using the CPAP and then BiPAP, your whole body ached when you got up in the morning. And I was here scratching my head. Normally I look for body pains to go away. Now I'm somehow causing body pains for Peter. And we tried the oxygen, and I remember at least what you told me at the time was that the supplemental oxygen actually made it possible for you to tolerate the BiPAP. As we thought about reasons why that might be happening, is you used to move around a lot more before you started using the BiPAP. Presumably with apneas, you would wind up arousing and moving. Then with the combination of your medications and the BiPAP, you were actually sleeping soundly through the night in a single position, and you were developing almost the equivalent of pressure sores / discomfort. Could be blood flow related, could not be. To be honest with you, the data on how oxygen helps is pretty weak. And I didn't believe it. You know, the person who first told me this was my father, who is a patient of sleep apnea, and he was developing body pains, and he went to see a Dr. Pachas, who was the head of rheumatology at Massachusetts General Hospital. That's one of the big Harvard teaching hospitals in Boston, where the New England Journal of Medicine is published out of, or at least their case records are published out of there. And the doctor said, the rheumatologist said, add oxygen to your CPAP. My dad told me this. I was a fellow at the time, and I said, that's a bunch of BS, Dad. There's no way that's really going to help. But it actually helped my dad. He went from using fentanyl patches and narcotics on a daily basis for body pains to not requiring the narcotics just by adding oxygen to his BiPAP. And that sort of led to my saying, when patients report they have body pains and they have sleep apnea, you know what, try the oxygen. If it helps, great. If it doesn't help, no harm done, and just move right along. And I think at one point that did help you. It made it possible for you to tolerate it. Your mom's nodding yes as well. I sort of have to go by what patients tell me, because I can't give you a good scientific explanation for why it works.
School must have been out the window. You were in high school at the time.
Yeah.
And you can't function in that setting. And I'm sure it was pretty confusing for you as a parent.
It was. We took him to every doctor we could think of. We went to teaching, to medical centers. We found specialists. We took him everywhere we could go. And we were often asked, maybe does he like school?
Right.
Is he depressed? Well, after about 6 months, we finally said yes.
I'm sure you got depressed. Mm-hmm. Yes, you're right.
Yeah, he did.
Yeah. So I just want to hear from you, just so people can get a sense on what a sleep study's like.
Oh, it's really not that bad. It's kind of, techie. You have all these little probes all over the place on your legs, all over your head, and you basically sleep. And they monitor it.
They monitor. So tell us a little bit about what it is and how you do sleep studies.
There are a few components to it. One is an EEG, an electroencephalogram, where we're looking at electrical activities of the brain, along with movements of the eyes and muscle tone at the chin. That tells us whether you're asleep or you're awake and what stage of sleep you're in. We look at airflow measured by the pressure in front of your nose, and you can imagine as you're sucking air in, the pressure drops at your nose, and we look at the temperature in front of your nose and mouth. Another measure of airflow every time you breathe. We have a belt around your chest and your belly to see, are they moving? Are you making an effort to breathe? An oxygen sensor sitting on your finger, and then an EKG looking at what your heart is doing, along with some electrodes on your legs looking for movements. You're like, how am I going to sleep with this? And my question to you is, how do you go through the day with this thing strapped to your wrist, suffocating it? Or for the ladies in this room, can you imagine going through the day with weights hanging off of your ears? They call these things watches, and they call these things earrings. And we get used to it, just like we're used to right now a piece of wood pressing against your funny bone on your left arm as you're leaning on it. Similarly, you get used to the wires. People drift off after a few minutes.
How much time do you need to record the sleep that's going to give you the information?
It depends upon what we're looking for.
Right.
Typically, even if folks typically will record for 6 to 8 hours at night. Most of the time, even if we get 2-3 hours of sleep, the times that we aren't getting sleep, we're seeing why they're not getting sleep. If we see these constant movements of their leg every couple of minutes, well, there's your answer, right? Or at least part of your answer. If as they start to drift off to sleep, we see apneic episodes, there's your answer. I would say probably 1 in every few hundred studies that we do, we don't get enough sleep, and we need to repeat it. But most of the time, there's enough of an opportunity to figure out what's going on.
And the mainstay of treatment, we've seen the oral devices, but we have a CPAP machine here.
Yeah. Ultimately, these things attach to masks. I sort of equate this to the airway collapsing as an issue of not enough pressure in a tire. You just need to inflate this. These machines don't breathe for you, but they pop open your airway. They pneumatically stent it open so that you can breathe. If I were to turn this on, at first you'll see it's fairly loud, and I have my mic on. Ultimately, it shouldn't be too much louder than a fan in your room. And by dotting this, looking like Darth Vader as you suggested, it's just creating a seal, and it's putting a slight amount of pressure. The blood pressure in your vessels is 120 millimeters of mercury for most people. This is on the order of 12 centimeters of water. That translates to about 10 millimeters of mercury. So it's 1/12 of that pressure, if you will.
That's all it takes.
That's all it takes, just a little something to pop open the airways so you can breathe. with enough experience, you could actually talk with these on as well. This one is a little intimidating in terms of size. As you heard me speaking, I wasn't yelling. I was speaking in the same tone that I'm speaking in now with the machine on. There's also what I would call sort of the bikini of masks, if you will. And these can be really quite minimal, where it just sits in your nostrils. You know, there are a number of folks who say, you know, I've heard of CPAP. All my friends who have it, it just sits in the closet. I would say it's sort of like a pair of shoes. If someone gives you a pair of shoes with rocks in it, or it isn't the right size for you, or it isn't comfortable, it's going to sit in the closet. But if you take the time and effort to work with your doctor, and with a group of with a durable medical equipment company or a group to find something that's comfortable, you'll be amazed at what a difference breathing can make. You know, it's just simple oxygen. So this doesn't look quite as intimidating, hopefully.
It looks a little more comfortable than the mask.
Would still say it looks a little crazy.
And so this is CPAP. Some people can't keep their mouths shut. They need what they call BiPAP. Is that it?
That isn't so much what drives BiPAP. So CPAP stands for continuous positive airway pressure. Mm-hmm. When I take a breath in and I relax, it's like putting air into a balloon. Right. The balloon is naturally relaxing. But if I'm pressurizing what I'm relaxing into, it takes effort to breathe out. So a lot of people who say they feel suffocated or smothered by CPAP, or just have difficulty tolerating it, or taking it off in the middle of the night and they don't know why, or getting a lot of gas and bloating in their stomach, they actually do better with BiPAP. And there, instead of it being a constant pressure, each time you go to exhale, it drops the pressure. And then for, as Peter had mentioned, or we talked about central and obstructive sleep apnea, it wasn't quite a ventilator, but it was a bi-level machine with a backup rate. For patients with heart failure, they have ones with fancy computers, which keeps it so you're breathing the same amount, breath after breath, as opposed to having what you may have recalled from Cheyne-Stokes respirations, where people overshoot and undershoot, and sort of like an elevator that's overshooting and undershooting.
And it takes some time to get used to that.
It does. It, you know, some people will say, I woke up the next morning feeling rejuvenated and born again, and that's maybe 5 to 10%. Right. But really, the other 90%, it's something which you've got to keep working at for months before people get used to it. I mean, a 3-month to a 6-month period of getting used to it is not unusual.
Well, with a lifetime of symptoms that they need to resolve, it's about time that they do that. So you've all heard a remarkable story here where there are a lot of things that we take for granted about our sleep and how significantly it can affect our health, our thinking, our bodies, how there may be hereditary factors that even cause early or premature death in many people as they have sleep disorders and that were never diagnosed or treated. So it's something to talk about with your primary care doc. If you have an issue, you're worried. Anyway, I do thank you all for being here with us and sharing your stories. And Dr. Machia, you certainly have enlightened us remarkably. And I thank you all for watching. And until the next time, I'm Dr. Russell Libby, looking out for your health.